Good afternoon, everyone. I think I'm the last speaker of the day, so hopefully I will keep my comments concise and keep you all engaged for this presentation. I'd like to thank Dr. DeVries and Dr. Price and the organizing committee for inviting me to speak. I think it's really been a terrific day, a terrific group of speakers, and I know I certainly feel very energized with new ideas that I'm hoping to bring home and apply to our own program. These are my disclosures, none of which will impact the content of my presentation. What I'm hoping to speak to in the next 20 minutes or so is around the development of our telesimulation program at the University of Toronto, specifically starting with the introduction and teaching of laparoscopy in resource-restricted countries. I'm hoping to tell you why distance learning is important, how telesimulation in our program works, some of its applications, and talk about future directions. So I think I'm preaching to the choir here when I read this quote, but one of the questions that I often get asked is, well, why are you teaching laparoscopy in resource-restricted countries? And so I often like to show this quote here. It's in the preamble to the WHO Constitution. And it says that the enjoyment of the highest attainable standard of health is one of the fundamental rights of every human being, without distinction of race, religion, political belief, economic, or social condition. Now, the challenges that each country faces in achieving that highest attainable standard will be different for each country, and many countries face many challenges. For some, it's obtaining a reliable, clean source of water. For others, it's improving maternal and newborn care. But certainly there are many countries with emerging economies that are starting to invest in medical and surgical technology. And so what I'd like to do is start by telling you about Botswana, where our program began. And Botswana is really one of these countries where it's a very classic example of the countries where we've been teaching laparoscopy. It has a population of around 2 million people. It has had a stable government and economy with a growing GDP over the last decade. And they have invested in surgical technology and equipment, such as laparoscopic equipment that you see here. Unfortunately, although they have well-trained surgeons, they have the equipment, they are lacking the training to use this equipment. Now, something very similar happened in North America and around the world when laparoscopy came out in the late 80s, early 90s. But the surgeons then started really experimenting or learning these techniques on real patients. And in these countries, there really is no need for that. There is a very large group of surgeons around the world with the skills that can train these surgeons that have the equipment to develop these skills. Just trying to go to the next slide. No. Just, oh, there we go. Now, in 2007, one of my pediatric surgical colleagues, Dr. Azzi at the Hospital for Sick Kids, he's been very involved in Botswana, and he invited myself and a group of surgeons to go and teach laparoscopy at one of their hospitals. Now, I have a master's in education, I have an interest in simulation research, and I've been involved with the FLS, or the Fundamentals of Laparoscopic Surgery program with SAGES, and I truly believe that simulation is the standard, and it is how we should be teaching new skills, as this gentleman is learning here over dinner. But I felt that if we were going to be traveling all the way to Botswana to do laparoscopic cases, it would be most appropriate and helpful if we could bring the FLS program there, bring some box trainers, and actually start teaching them, in addition to obviously in the operating room, but leverage that teaching on the FLS and the FLS simulator. Now, for those of you that aren't familiar with this program and with the simulator, it is low tech. You can see it here. It's in a box. It fits in a suitcase. It is quite inexpensive. The box itself, if you were to order one, is about $1,500, which I guess is not cheap either, but certainly the materials you can put in a non-FLS box as well, and you can make a box for much cheaper than that if you don't purchase it from SAGES. But you can see many of the materials there are reusable, and as well, the skills that you learn aren't specific to one operation. They are useful to anyone that wants to do laparoscopic surgery, be it gynecology, thoracic surgery, or urology, in addition to general surgery. And so we brought this course, we taught the didactic content, we gave lectures, we taught on the simulators for several days, and we measured their baseline skills and compared it to their skills after our workshop, and we published our results here. You can see there was a dramatic improvement in their performance over 3 days. Now, an expert, however, on the FLS simulator will score typically over 80, 90, even up to 100 on the simulator. And so, unfortunately, we were only able to certify 10% of the surgeons when they took the actual certification exam. So you can imagine on our flight home and in leaving, yes, they had improved a lot, but there was some disappointment here. It takes a long time to travel to Botswana. We didn't think we would be back for one more year. They really wanted to get that certificate that they could put on their wall. And so this is where the idea for telesimulation came to us. We saw that there was a camera in the simulator. It was connected to a television. Well, why not use that camera and convert it into a webcam? And Skype is free. Really, many people have computers, and so let's set up this environment where we can try to teach them remotely. And so this is the model that you see here. This surgeon is in Botswana, and on the screen on the left is what I'm doing in my box, and the screen on the right is what he's doing in his box, and we can see each other and communicate in real time. And I'm just going to show this to you in a brief 20-second video here. Hi Oscar, how are you?
Hola Alan.
Today we're going to practice suturing. This is how you hold the needle. Grab the needle at the tip. It's important to be accurate. Aim for the black dots. Orient your loop this way. Now go ahead and cut. Very good, Oscar. I'll see you next week.
Okay, see you next week.
So once we showed that this was possible to do, again, we wanted to really look at, in a critical fashion, if this was actually effective compared to what we were doing before. So we went back to Botswana, and we had a natural control group in Francistown, which was higher to the north, where the internet access was not as good. And so we returned there, we left the box in both cities, in Gaborone and in Francistown, and we told them, practice as much as you can over the next 8 weeks, and we're going to come back and try to recertify you. In Gaborone, the capital, we met with them weekly and practiced with them for approximately 2 hours. And there were 8 surgeons there, so each surgeon would have about 15 minutes of time with the instructor. And the idea here was that, yes, they would be practicing during the week, but we would be helping to correct their errors and improve versus the self-practice group. You can see in the telesimulation group now, their FLS score is 88 compared to that in the non-telesimulation group, and we achieved 100% passing rate in the telesimulation group versus 38%. Now, over this period of time, and this is not purely all because of our simulation program, but you can see that in Botswana specifically, after they invested in their equipment with Dr. Azi's work and with our simulation training, that over a period of 4 years, a dramatic increase in the number of cases attempted and completed laparoscopically up to 2008. And now most of their cases are done laparoscopically there. Once we completed this particular study, we experienced a dramatic expansion of our telesimulation program around the world. We've now taught in over 10 countries that you see listed here. We've trained over 200 participants in the FLS program. And typically, we really follow the same curriculum that we used in our initial study. We will go and bring the equipment. And that initial visit is actually important, where you get to shake hands and meet people and explain to them about the program and really build trust in your team and in the training that's going to happen. We then do 1 session per week over 8 weeks, and we train them really to proficiency during that time. And you can see here in all the countries a very similar scores after the 8 weeks of training really around the world. We've surveyed surgeons and asked them what they think about simulation training in resource-restricted areas and telesimulation specifically, and you can see that overwhelmingly the participants find this to be very useful, and they want more of it when the course is done. Now, we've been very fortunate and blessed that we have been able to raise funds through our hospital foundation and name a telesimulation center, the Temerity Chang Center. And the goal of the center really is to now expand beyond laparoscopy and say, well, if we can do this with laparoscopic skills, why can't we do it with all medical skills training? And so we've now developed a curriculum where our OR nurses have actually have a lecture and simulation-based component where they can train other nurses around the world. We've taught intraosseous needle insertion. We're piloting a program, or developing a program really, for high-risk obstetrics. And obviously we cannot train the entire world through this program, and so one of the key components is training trainers. And so we've been able to establish satellite telesimulation sites. One is in Medellin, one is in Donetsk in the Ukraine, and we're currently working on establishing one in Beijing in China. Now, Canada faces very similar challenges with training in remote areas as you face here in the United States. And so going back to FLS, there are only 3 FLS certification centers in Canada. And so there are challenges to certifying Canadian surgeons in this particular course also. Travel is not practical. And so we were able to obtain funding to pilot this throughout Ontario also, and you can see here we trained 40 surgeons in remote parts of Ontario, achieving similar results that we have in many countries around the world. What was most amazing about that particular program was that almost all of the training of the surgeons within Canada throughout Ontario occurred from our satellite telesimulation site in Medellin. That's where one of my surgical colleagues, Oscar, who works in my lab, but he also works in Colombia where he has a practice, and he does most of the training in laparoscopy. And so he did most of the training from Colombia back in Canada, and I just think that is remarkable. Now, of course, simulators are not real people, and eventually it's important to actually start to treat real patients. And so, yes, obviously we operate with patients, with surgeons when we go back to these countries, but in order to leverage that training, we are now starting to look at telementoring. This is not something that is new. It's been done in many countries, but certainly doing it in resource-restricted settings has its own challenges around bandwidth and, again, the cost. This was a case, the first case that we did while doing a course with SAGES in Peru, and maybe I'll just have you run this video here. I'm the surgeon here in Peru. This was the first time that we were doing it. But this is, again, shown over Skype, and the quality is not as good as we would like for independent telementoring, but you can see here that it is still quite good. You can identify here the critical view for the general surgeons in the room, clipping the cystic duct and the cystic artery. And this is where we're trying to move now, looking at telementoring following telesimulation in various countries, but also within our own country in Canada. We're looking at setting up a telementoring network and a matchmaking service that will allow surgeons in remote communities to be mentored by surgeons in more academic centers that have the skills to teach. Now, there are still obviously challenges, and just to name 2, one has to do with bandwidth. Obviously, in many of these countries, high-speed internet is a challenge. We've done some work looking at the quality of the picture that you get, the reliability that you get in assessing someone's skills, depending on the bandwidth that you have. And we have, without a doubt, showed that with a higher bandwidth, there is more reliability of your assessment and the teaching that you can do. One of the solutions that we found that's actually worked quite well, even though plugged-in high-speed internet can be challenging to obtain, 3G networks and the cellular phones are something that are readily available in almost all countries. And I know there's been many references already made to mobile technology and cellular phones, and by getting a 3G data stick and plugging that in, we've been able to do telesimulation training over Skype using that with very good quality. One of the other challenges, obviously, is language and time changes. We've gotten around that so far by having fellows in our lab from China, from Latin America, do the teaching, but obviously that's not necessarily the best option. We are doing some work, again, with SAGES and with IBM, with the IBM Watson team. I'll just have you play this video. This is the same video that you saw earlier, except here, there is a computer and some IBM software that is automatically creating subtitles in Chinese here. So this is something that is very much a prototype right now, but you can imagine if this was available in the 10 or 12 most commonly spoken languages in an automated fashion, how powerful this would be. Steven Schweitzberg, our former president of SAGES, recently did a TED Talk on this if you're interested in learning more. So in conclusion, I think telesimulation is a novel and effective way of teaching medical skills around the world. It's cost effective, it's time efficient, and it certainly allows for more distributed practice versus clustered practice that we tend to do in these on-site courses. There are obviously challenges, but hopefully I've been able to show you that it is, I think, a very promising technology and way to teach. Thanks very much.